Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Okay, so since now we are on record, let me just begin the class by saying that now we're on the verge of finishing off the infections in pregnancy. I took you through a long and tedious journey of so many infections that we did. We started right from the beginning of, viral infections, which are too many with their own specific catastrophic events, teratogenicity, profiling, right to the, diagnostic parameters. Many of them had difficult, tests like when is IgM important, when is IgG important, titers, how important they are, what is avidity testing, for which tests, which infections is avidity testing important. Then I took you through very important infections, apart from, of course, the the group of infections, the combo, groups that I'm going to bring up now. For example, STDs in pregnancy, or protozoal infections in pregnancy, or bacterial infections in pregnancy. I took up classes on hepatitis in pregnancy, very conceptual topic. STD, HIV in pregnancy, again a very oft repeated question and topic in your exams. And then finally, now we are on the last bunch of few topics which are important nevertheless and conceptual. Why? Because I took a class pretty recently and it's there on YouTube, a snippet of which I've included in this lecture as well, on decoding the tests of syphilis. It was very poorly given in YouTube. None of the lectures, were able to give you in a nutshell what you need to know. All right, so they were very long lectures. Even I had a tough time, to understand what exactly is one lecture telling, what is the advantage of one over the other. But it was like 20 minutes, or more than that, 30 minutes. Who has time to go through such long lectures? You should be able to get the gist in couple of minutes of a lecture, and that too pretty clear in your mind. That's what I call a class in which you can just tell in a nutshell what you need to know, from both examination point of view, practical point of view, and from your day-to-day interactions with the patients. So a couple of students might join in later. It's already 9:03 by my watch. I think it's good enough to start today's chapter. And today's class is about STD infections in pregnancy, which I have narrowed down to syphilis, gonorrhea, and chlamydia. Why? Not just because they're very prevalent, also with the fact that they have a notoriety of being asymptomatic. Now, if you do remember, when I was speaking about viral infections in pregnancy, I was very concerned about those infections in which the mother is asymptomatic, and the direct impact is that on the baby. When I was speaking about GBS infection, I hope you do remember how important that infection was, because the mother is asymptomatic, but it is very bad for the baby. Anyways, so we begin our class today with syphilis, gonorrhea, and chlamydia. And I begin with syphilis first. So I hope you do know that it's a motile spirochete, and it's called as Treponema pallidum. Spirochetes are many, okay? They cause many other diseases like yaws and pinta. So you have, Treponema pertune and stuff like that. But Treponema pallidum is the one which is associated with syphilis. And now we're talking about syphilis, right? So let's focus on Treponema pallidum, which is a spiral shaped organism, and it's got tapered end. One of the commonest causes of ulcer formation. So if a patient comes to you with the ulcer in the genital area, first suspect syphilis, then suspect anything else. And it is painless, okay? So might as well be easy for you to, kind of differentially diagnose it. Transmission of the disease occurs through breaks or cracks in the skin or mucous membrane, and by usually heterosexual or homosexual or oral sexual contact with an infected person. It can be transmitted in utero, that is, vertical transmission is very much there. In fact, you have a syphilis syndrome, which is going to be coming up. What is now the natural history of the disease? Okay, so you have an untreated patient. Let me specify now, syphilis is next to nothing. You might not be hearing these cases very often, but you do, because only the primary syphilis is now known. Why? Because first of all, the diagnostic techniques, number two, the treatment, and above all, the what do I say, the awareness of the patients to reach the doctor, the availability of doctors. So it has become a a disease. It's painless ulcer, to be very, that's the most important thing. So patient just feels that it's just an itchy thing out there, and and they start applying, the lotions or the creams themselves, not understanding that how bad can it really become. Now, if you go and see the pictures of tertiary syphilis on net, you'll be scared to death because they're actually very, very catastrophic images. And earlier on, this disease used to reach that level of, what do I say, notoriety, because it was not studied properly. Treatment was, kind of dicey. People did not know. Antibiotics were rare. I'm talking about many years, centuries back. But now you will not see those stages. Why? Because patients, they are not only aware, but even if when it kind of manifests or spreads or something, they have this kind of urge to at least show it once to the doctor. And once if you show to the doctor, every doctor now, writes at least a prescription of an antibiotic, which will definitely include one cephalosporin, to say the least, which is actually a penicillin group of antibiotic and provides relief from this infection. So I'm just giving you an outline. So I'm talking about an untreated patient. If the patient does not get treated, then that patient is going to go through these 4 stages. These 4 stages are primary syphilis. Okay, here's the slide. I'll talk about it later. Secondary syphilis, latent syphilis, if you can see over here, tiny little line on latent syphilis, and finally the tertiary or the late syphilis. Okay. Now, when it comes to primary syphilis, so if you can see over here, these are the punched out kind of lesions which are there on the penis or labia majora, minora. So they're called as hard chancre. That's what it's called. The primary, this lesion in syphilis is called as chancre, usually found on labia majora, minora, fourchette, clitoris. We're talking about females. We're gynecologists, so obviously female patients will come to us, not the males, but this is how it looks like. Okay, can you see this typical lesion? Primary lesion may be multiple in 10% of the cases. An incubation period lasts from 10 to 90 days, as small as maybe 1 week to as large as 3 months. The first lesion is nothing but a small papule which quickly breaks down, forms sharply defined serpiginous ulcer with brownish red color. It's got raised borders and an infected base. An ulcer may become painful if it gets secondarily infected. Otherwise, it is painless, which is the reason why it might go on to the second stage. Okay, the primary syphilis might lead to the second stage as well because of ignorance or just avoiding this problem. And usually, very important thing in India, we have this taboo. Once the thing starts growing in the genital area, people are very shy to come up and to reach for help. So that is also an important thing of it going to the second stage. Otherwise, usually it is easily managed in the first stage. So the ulcer may become painful if it's secondarily infected. They may be painful in discrete inguinal lymphadenopathy without suppuration, and the primary lesions, they heal without any treatment within 3 to 9 weeks and earlier. That means even if you do not treat it, it will go. So people are very happy it's gone, but that might move on to the second stage. And here, a very important line is that serological tests over here, they are positive only after 1 to 4 weeks of the primary lesion, which is very important. That means if you do a test, if these lesions can be seen, if you do a test, it might not come positive for syphilis. So remember that it takes 1 to 4 weeks for the serological test of syphilis to come positive. That means I'm talking about your VDRL test or EIA test, which you very easily refer to. In a patient with these kind of ulcers, punched out ulcers, you will write down VDRL and comes negative. Oh, it was not syphilis, then what could it be? So it is not true because it takes around 1 to 4 weeks time for the serology to come positive. Then this is the secondary syphilis kind of a lesion. Develops in 6 weeks to 6 months after the primary lesion. Okay. Why? Because now the spirochetes are entering into the bloodstream. You did not take care of the, the local lesion. Now they've gone into the bloodstream. And now they'll cause symptoms like malaise, anorexia, sour throat, headache, pyrexia. And this is the time when intervention usually takes place and the person can still be saved from going into the tertiary stage, which is really horrid. Okay, so all these things you have, these maculopapular skin rashes are coming up. They might even come in mucosal membranes. They might come on skin. So now things are getting slowly evident. This genital region, the ulcer went away. you were very happy that finally, okay, at least I don't have to go to the doctor, and now it has gone in the bloodstream and it started affecting the entire body. Now there is a cause of concern, and this is the place where the patient might get the appropriate treatment.